All right, so hopefully you are all not experts on this already, and we'll actually have a nice conversation here. My talk should not take the entire hour, so I'm happy to entertain any questions throughout. So please feel free, especially Dr. Pell. I'm looking forward to your questions out there. So the Institute of Medicine in 2011 said LGBT, lesbian, gay, bisexual, and transgender individuals have unique health experiences and needs, but as a nation, we do not know exactly what these experiences and needs are. We'll talk a little bit more about this and the goals that the Institute of Medicine and the Department of Health and Human Services have put out in regards to LGBT patients. But I'll tell you, as a spoiler alert, we've not made much in terms of headway in understanding these experiences and needs. We have a lot of work still to do. So hopefully by the end of this presentation, we'll understand some common terminology as it relates to LGBT patients and the care of them, understand health disparities that LGBT patients face, understand barriers to health, and then understand some population-specific guidelines and translate those into the clinical setting. This is truly an Intro 101 course to LGBT health, but if you'd like more detail on any of it, I'm happy to entertain those talks as well. So let's start with terms and definitions. This is really the baseline and the building blocks here. So in order to understand your patient in front of you, you have to understand the culture from which they're coming from. In the LGBT community, just like a lot of things in the world right now, we love to put acronyms in it. LGBTQIAA, it's truly the rainbow of letters related to this patient population. And understanding those letters and understanding the terminology behind it will actually help you understand the patient in front of you a little bit better. So lesbian, gay, bisexual, transgender. You'll hear the term that's used a lot in the community is queer. Some of you may say that's a very disparaging word. It's actually been what they call reclaimed by the community, and they use it in an empowering way. And then the Q can also stand for questioning. There's intersex, there's asexual, they'll also put allied. There's actually a lot more than this, but this gets you at least the basics going. So for me, it's really important that the patient in front of you, you understand that sexual orientation, gender identity, they are not equal, okay? Just because someone identifies as gay does not mean that in reverse. Just because someone identifies as transgender does not mean they are gay. Okay? All people have a sexual orientation and gender identity. For some, that may change over time, and depending on your culture, your background, that terminology may be unique and may not actually apply to what we're talking about today. But it's really important that it does not equate with sexual orientation. So what is sexual orientation? Sexual orientation is how a person characterizes their physical and emotional attraction to others. It's made up of three main domains: behavior, attraction, identity. As a primary care physician, behavior for me is very important because that dictates what clinical tests that I'm going to be running, questions I'm going to be asking, and it also helps me to risk stratify the patient that's sitting in front of me. Identity and attraction, they're important aspects of this, but that's more from a psychosocial component of it than a true behavioral side of it. Behavior is what dictates risk. So if I may just give you an example here, if someone identifies as straight or as heterosexual, they may have an attraction to women, they may identify as straight or heterosexual, and they may have sexual intercourse with someone of the opposite sex. Okay? However, just because someone identifies as heterosexual does not mean that they're not attracted to someone of the same sex or that they don't have sexual intercourse with someone of the same sex. So there are truly three domains. We like to think that they all interact, but that's not always true. Sexual orientation is not determined by one factor. This has been shown in multiple evidence-based studies. It's a combination of genetic, hormonal, and environmental influences. It's established by early childhood, and it's not influenced by abnormal parenting, sexual abuse, or other adverse life events. Let's talk a little bit about gender identity. Gender identity is your internal sense of being male or having maleness, being female or femaleness. It may also be an internal sense of being both, being what they call gender fluid, or having no gender at all. You think of gender, it truly is a societal construct. Gender is separate from anatomical sex. Okay? Gender is truly that internal sense of being male or female. Transgender people have, as we just said, a gender identity that's different from their birth sex. Common terminology, although this is not an all-inclusive list, is transgender woman, a trans woman. If you hear that terminology, that means that that is a patient who likely had anatomical sex of male, but has a gender identity of female. The same is true for a transgender man or trans man. It's a person who has an anatomical sex organs that would typically be phenotypical for female, but identify as male. And then you can have, as we talked about before, that queer terminology that shows up in genderqueer or gender fluid, which means that they truly don't identify in that binary system. That is culturally driven. In Western society, we tend to have binary in terms of gender identity, but there's a lot of societies, especially if you look at Native Americans, that do not have a true binary system in terms of gender. If you hear the term cisgender, that's a term for non-transgender people. I like it because it brings me back to my organic chemistry days with cis and trans, but cisgender is a non-transgender person. And that's the terminology that you'll see in the literature as well. So how many people are LGBT in the US? This is really hard data to obtain because, one, not everyone who has same-sex attractions identifies as LGBT or T, and not all individuals who identify are able to be captured on any national type of survey. That changed in 2010 slightly when the national census did include same-sex couples on the census. So some of this data is actually driven from that census data, but this likely is an underestimate, although this is the best data we have. So 3.5% identify as LG or B. Women are more likely than men to identify as bisexual. 8.2% report same-sex contact, and about 11% report at least some same-sex attraction. I am a professor at USF, and occasionally they ask me to give a conversation with their medical students in LGBT health, and part of that, they have a clicker system, so it's all anonymous, and I love doing this because I get a whole bunch of questions, and people are free to answer however they want without fear of peer pressure or looking at how is anyone else answering. And part of the questions ask, how do you identify? What is your attraction to same sex? Have you thought about having a same-sex attraction? Have you ever had a same-sex, however you want to define it, event where you've either had personal contact, intercourse, etc. The numbers are quite staggering. It roughly represents 3.5% identifying as LG or B. In terms of those who have thought about same-sex attraction, the numbers went up to 25% of the students that were in front of me. So you look at that and you say, okay, maybe identity and behavior and attraction are truly three different constructs. This is based on that census data that we discussed earlier. These are their same-sex couples, households by county in the US. It's in typical areas that you might think of, New York, LA, but there's actually a lot of same-sex couples in the Southeast specifically. The New York Times did a great article a few years ago, and actually the most number of same-sex marriages occurs in the Southeast part of the US as opposed to any other part of the country. Reasoning for that might actually have to do with Southern heritage and the importance of family and the construct of family and the wanting of acceptance from their other family members. So as a primary care doctor, I take a sexual history all the time. My MA helps me out quite a bit with this in terms of getting all the data into the EHR that we all have to deal with. But a sexual history for me is really important in understanding that behavior component as well as the psychosocial aspect of the patient sitting in front of me. If you are not a primary care physician, maybe this is a little bit less important, but hopefully by the end of this conversation will convince you that it's important for every physician, no matter how you interface with the patient. So taking a sexual health history, it's a really part of the core comprehensive exam that you're doing. It should be the same. You should treat it the same for all patients, whether they identify as LGBT or T or they identify as anything else. You really should have the same core competencies when doing a sexual history. You should make no assumptions. That's the hardest part. We all come in with biases. Everyone who I look at in an exam room, part of my heuristics and allowing me to get to a diagnosis allows me to make quick decisions, and that's all based on biases. It's not necessarily that bias is a bad thing, but sometimes it actually prevents us from taking really good care of our patients. And so as long as you're aware of your biases and you can check them at the door, or at least hold them in, okay, this is where I'm at, that is an important part of taking care of your patient. Doing a sexual health history actually is a really important part of your social history for all those psychosocial reasons that we talked about. I can tell you I have a number of patients who are married, men, who are married to female partners who have behaviors that some of you might consider as gay or homosexual because they actually have sex with men, but they identify as straight and they are sure that they are straight. For me, like I said earlier, it's not necessarily important their identity outside of the stress that creates from having an identity that may mismatch with their behavior. The biggest thing for me is risk stratifying them and making sure that I'm ordering the appropriate test and taking really good care of them. A lot of patients are going to want to make sure that what you're doing and what you're typing into that EHR is going to be confidential. If you have adolescent patients, you may choose not to put all of that information into the EHR, and that's actually supported by the American Association of Pediatricians, or the American Academy of Pediatricians, excuse me. Part of the reason for that, obviously, is that parents have access to their children's records, and your head's assessment is still part of that record. And if a parent and if that child does not want the parent to know their sexual orientation or that they might be questioning their sexual orientation, you may have issues there. And so for me, what I tell all of our residents is that it's not necessary for you to document every single thing the patient tells you, only the pertinent parts. That's a learning curve, I think, for all of us. The CDC has put out what they call the 5 Ps for sexual health assessment. I think it actually does a really nice job of making sure that you always remember to do the pertinent parts of a sexual health history. The first thing is, who are your partners? Do you have sex with men, women, both? That's a typical question I'll ask. Some patients are surprised by that question. I'll tell you, I've seen a lot less surprise with that question over time. It's just becoming part of the vernacular in medicine to ask about the partners. Practices, do they use IV drugs? Do they use other chemicals during intercourse? There's something called poppers that people use. These are amyl nitrates. They cause a vasodilatory response. It creates a euphoric sensation, a high. There's also a lot of IV drug use that may accompany sexual intercourse, as well as practices like crystal meth. There's a lot of those type of practices that you want to make sure you're assessing, and this is a good part to put in as part of your sexual health history. Past history of STDs, were those STDs treated, were they not treated? That also helps you risk stratify for future STDs. Are they using protection, condoms, barriers, etc.? And pregnancy plans. What are their pregnancy plans? Again, this is part of that bias-y component, is making sure that just because you have a patient who identifies as lesbian, does that mean that they don't want to get pregnant? That's not necessarily true. And you do want to assess what their pregnancy plans are. Do they want to be on contraception? What their contraception options are, and discussing that in detail. CDC has a really good website on this, and if you're interested, I encourage you to go to that. It's located right there at the bottom of the slide for you. I'm going to shift gears a little bit. If anyone has any questions, feel free to jump in. But we're going to talk about stigma and discrimination here and why this is important in the life cycle of an LGBT patient. So what are the effects of stigma on health? Well, fearing discrimination by healthcare providers affects access to care. If you think that your healthcare provider is not going to want to treat you, then you may not access that care. Regardless of reality, perception is reality. And if they've had one bad experience with a caregiver or caretaker in the past, whether that's a nurse, a physician, an MA, etc., that's going to impact their ability to access care in the future, because they may stay home instead of getting to the primary care practice, the provider early, they may stay home until they're really sick and they have to go to the emergency room because they don't want to face discrimination. Daily stressors caused by that stigma, again, real or perceived, either way it's real to them, and that causes a lot of distress, and it can lead to adverse mental as well as physical health outcomes. And internalized stigma obviously can cause self-harm and unhealthy risky behaviors, whether that's smoking, whether that's drug use, or suicide risk. There was a large campaign several years ago called the It Gets Better campaign that launched as a result of a number of LGBT youth taking their lives. And I don't know if any of you are familiar with that. It was a YouTube kind of thing that went viral where people got on YouTube and said, hey, it gets better, don't worry, adolescence sucks for everyone, don't take your life. But we'll talk a little bit more about the real risk of suicide in LGBT youth. It's actually quite staggering, the statistics. LGBT life issues. The process of coming out as LGBT, that is a lifelong process. It instills a lot of fear in individuals to this day, although times are changing. I will tell you there's a lot of high school students out right now that are very out, proud, and they are the most popular kid at school. But that's not true in all parts of the country. Certainly not true where I was at in high school. We didn't have anyone that was out as gay. But that is changing. That process of coming out, though, is a very personal experience. And just because someone is out to their friends or family members does not necessarily mean that they want to be out professionally. And if they are, quote, outed, that may have very adverse effects on their health, especially their mental health. Rejection from family is a very real issue. The most number of homeless youth identify as LGBT, and that's either because they decided to leave their family or they were kicked out of their family housing unit. Marriage, civil unions, other commitments, the terminology has changed, obviously, and we've had recent societal changes, especially in this country, but that still is an ongoing topic in society, and that can create negative or positive impact on the patient. Becoming parents, whether that's through adoption, insemination, surrogacy, if they're female and they want to have insemination, make sure you talk to them about their cardiovascular risk, as we just talked about in the last conversation here. End of life advance directives. With the marriage becoming a little bit less of a societal hot topic here, we've seen a little bit less of this in terms of hospitals being in the news for rejecting same-sex partners in that end-of-life discussion, end-of-life care. But that doesn't mean that it's gone away. There was just a case out in Iowa a couple weeks ago where a same-sex couple, one was dying and their partner was not allowed into the room at the time. So it still exists, even though it is becoming less frequent. Discrimination in housing, work, and children's education. And then part of that is making sure that you're asking about these questions, not necessarily all of them, but just their life issues in general, and be able to listen without bias. Again, that's really difficult, but at least understanding where your biases come from. And if you're not comfortable making those decisions or helping that patient, make sure that you are treating your patient by referring them to someone who is. So the Department of Health and Human Services put out their goals. Are called Healthy People 2020. And part of those goals were related to LGBT patients. What the Department of Health and Human Services found is that LGBT youth are 2 to 3 times more likely to attempt suicide than their heterosexual cohorts. They are more likely to be homeless. About 40% of homeless youth are LGBT, and they're higher risk of HIV and STDs. LGBT populations have the highest rates of tobacco, alcohol, and other drug use compared to the general population. A lot of that comes from that internalized stigma that we talked about. There's also, this is changing generationally, but if you look at LGBT patients that grew up in the 80s and the 90s, part of where they met people were in clubs, and the club environment lends itself very easily to tobacco, alcohol, drug use. The tobacco in particular, the tobacco companies are very good at marketing. They really are just truly a marketing company. And they marketed LGBT patients very heavily during that time and still do to this day. Gay and bisexual men and transgender women are a much higher risk of HIV and STDs, especially among communities of color. We'll talk about HIV risk here shortly. Lesbians are less likely to access preventative service for cancer and more likely to be overweight or obese. We'll talk about those preventative services for cancer, but the numbers are striking. If you are female and you identify as lesbian, you are much less likely to be offered a mammogram and a pap smear by either your family doc or your OBGYN or your internist than someone who does not identify as lesbian. And the risk of pelvic cancer, of cervical cancer as well as breast cancer, in most cases they're about the same, but actually with breast cancer the risk is higher in lesbian populations, and yet they're using those preventative services less. Transgender people experience very high rates of victimization and suicide attempts. In fact, just recently the FBI put out some data on victimization of transgenders, transgender people, and the numbers are quite staggering. Hate crimes, whether you like that terminology or not, since all crimes are motivated by hate, but those that were targeted because they were transgender are on the rise in this country. The Attorney General recently put out an effort to try to increase at least prosecution of individuals who are victimized as a result of being transgender. Older LGBT adults, that really can be a conversation in and of itself. but they face a lot of barriers to healthcare for a lot of reasons. One is societal and generational. They're a lot more likely to have isolation, fewer family support, and lack of social and support services. So what are the goals that Healthy People put out? One is to have national representative data on LGBT Americans. We've made some progress there, but we're nowhere near where we need to be. Prevention of violence and homicide towards the LGBT community, resiliency in LGBT communities. What that is referring to is looking at, despite all the past and current discriminatory practices that may have been in place, how are these individuals resilient over time and what coping mechanisms have been utilized? LGBT parenting issues throughout the life course, elder health and well-being, exploring sexual and gender identity among youth, talking about an LGBT wellness model, and recognition of transgender health needs as medically necessary. So this is from the Department of Health and Human Services, their goals. There's been some progress on some of these items, but most of them have not really been explored at all. So we'll talk a little bit about these 4 health concerns. This is certainly not comprehensive, but we'll talk about HIV prevention and STI screening. And I know we had a conversation yesterday about HIV, globally speaking. I'll focus a little bit on the LGBT population, but I promise you I won't belabor the point. We'll talk about smoking cessation, preventative care, and youth issues. So HIV, when I looked at the data most recently, I was surprised because I actually had to update my data recently based on the most recent CDC information that has been put out. For the first time, annual HIV infections and diagnoses are actually declining. This is based on 2015 data. The annual number of HIV diagnoses fell 9% between 2010 and 2014. Part of this, at least, is hypothesized to be due to targeted HIV prevention efforts. Some of you may be familiar with the term PrEP, which is pre-exposure prophylaxis. There's also something called NPEP and OPEP. OPEP is occupational post-exposure prophylaxis for individuals who are in the healthcare setting who may come in contact with HIV, hepatitis, et cetera. NPEP is for non-occupational post-exposure prophylaxis. So if you had a high-risk event and you present to a physician or clinician within a specified time frame, you'd be eligible for prophylaxis based on a risk stratification. And that prophylaxis, again, depending on what the indication is, but it's usually a HAART regimen for 28 days. Progress has been uneven. There's been one group in particular, Hispanic and Latino, gay and bisexual men, where it's increased. Among white, gay and bisexual men, the rates decreased by 9%. Among African American gay and bisexual men, diagnoses increased 2%. However, what the data is exciting, at least from my perspective, is that for the first time we've seen among young African American gay and bisexual men, it's declined 2%. For years, that data has been showing quite the opposite in terms of new diagnoses of HIV. Among Hispanic and Latino gay and bisexual men, discouragingly, the diagnoses have increased 13%. So terminology, this is something I haven't defined before, so I apologize. This is what's used in the literature. That refers to men who have sex with men. WSW is women who have sex with women. Again, rainbow of letters, but this is actually probably the most accurate way of doing it. This does not stand for mainstream media, I promise you that. But this, again, gets at behavior as opposed to identity, and that's how most medical literature describes men who have sex with men or women who have sex with women when talking about different ailments. In this case, living with HIV, MSMs are more severely affected than any other group, 2/3 of new HIV infections. And a majority of people living with HIV are MSMs. It's estimated that around 10%, a little bit more than that, of men who have sex with men are HIV positive. In many major US cities, it's 1 in 5. Among people aged 13 to 24 who are living with HIV, this is scary to me, 44% did not know that they had HIV. So for me, that gets into the primary care physician role of making sure that you understand the risk of your patient based on their behavior and that you're doing appropriate screens. So new diagnosis of HIV in 2015. This just looks at, based on subpopulations here in terms of who is having the most acquisition of HIV. It's still disproportionately black male-to-male sexual contact compared to the other cohorts. But again, we talked about earlier that the Latino population has seen a 13% increase in HIV diagnoses. In terms of where this is in the country, Florida, right there. Actually, Hillsborough County and Pinellas County, Florida has the great distinction of having being the number one state in the country of having new HIV diagnoses. Hillsborough and Pinellas County, which the counties are in right now, Tampa Bay is Hillsborough, Pinellas is here, rank in the top 3 and 4 in the state. And those numbers, at least in this state, have been increasing over the past several years. Lifetime risk of HIV by state, you may want to close your eyes, but if you live in Florida, you have a 1 in 54 chance of having HIV in your lifetime, just based on the numbers. That's quite staggering. Transgender women, that would be male to female patients, are at very high risk. Estimated prevalence, although again the data is suspect on this because we don't have a lot of those data points, but transgender women have HIV prevalence of 28%. That's 56% of transgender African American women. Transgender women are 49 times more likely to have HIV than other adults of the same reproductive age. So as a primary care doctor or physician out in the community, how can you improve your HIV detection and prevention? The USPSTF has a grade A recommendation of instituting universal HIV screening for all adolescents and adults aged 15 to 65. So if you fall within that age category, you should have had at least once in your lifetime an HIV test performed. That's regardless of other risk factors. It may be more frequently for what they call, quote, high-risk groups, which include IV drug use, men who have sex with men, and transgender female patients. Among those high-risk groups, the recommendation usually is at least annually, but it may be more frequent or less frequent depending on their true risk. The other important part of this is make sure you have the correct support services. The worst thing that I want to do is if I have a suicidal patient in front of me is to diagnose that they're suicidal and then have nothing to do for them. That's probably the worst scenario I'd find myself in. The same actually translates over to making sure that when you're detecting HIV that you have an appropriate support service, that you can either treat them yourself, refer them for treatment, and make sure that you have appropriate psychosocial support in place as well. We talked about PrEP and NPEP earlier to help prevent HIV in the first place. In terms of what tests should we be using for screening for HIV, the recommendation is to use the 4th generation HIV screening test. That's a combination of P24 antigen for HIV-1 and HIV-1 and 2 antibody differentiation. That can detect up to as early as 14 days after an event in terms of HIV infection. It's still not quite as good as HIV PCR testing, but it is very close to, we've got it now within 2 weeks compared to 1st generation testing, which was 60 days post-event. I will tell you just one more piece on this. With the antibody differentiation testing that occurred, the algorithm goes perform the P24 antigen testing, then do an antibody differentiation. As a clinician, the results you'll get back is that it was repeatedly positive for the antigen, and then you'll get an antibody differentiation testing back. That antibody differentiation may say HIV-1 positive, HIV-2 positive, or it may have a combination of both of those. If you see a combination of both of those, your first thought should not be that you need to call the CDC because you've discovered a very rare HIV strain, or that the person is co-infected with HIV-1 and 2, because that is extremely rare in this country. More than likely, there was some cross-reactivity between the antibody differentiating testing, and you should confirm with PCR testing. I actually just had a case of that this past week. Antibody differentiation came up positive for both 1 and 2. PCR confirmed it was an HIV-1 infection as opposed to HIV-2. Hepatitis C, as we know, hepatitis C and HIV, they're frequently co-infected. 3.2 million are infected with chronic HCV in terms of men who have sex with men. There's growing evidence of sexual spread with co-infection, and screening is especially important for these patients. It's recommended for all HIV-infected men who have sex with men to have at least one time screening for hepatitis, but that's actually true of all patients who have infection of HIV regardless of their sexual practices. And then emphasizing the use of condoms to prevent spread as well as treatment to prevent spread. Men who have sex with men are at higher risk for HIV, syphilis, gonorrhea, chlamydia, viral hepatitis, herpes, and HPV. We'll talk a little bit more about HPV and some of the controversies with that here in a second. As far as syphilis goes, there's actually, I don't know that I can technically and scientifically say an outbreak, but Anecdotally, I can tell you that in this community, syphilis is on the rise, especially within the MSM community. Just this past week, I had 4 new diagnoses of syphilis in that cohort of patients, and more frequently, and which should be the most alarming part, is they're becoming resistant to current treatment practices. So just be on the look for that and make sure that it's part of your universal screening for any of your patients who are MSMs. So annual testing per the CDC for all MSMs is HIV, syphilis, hepatitis B, hepatitis C, and chlamydia and gonorrhea. And I'm sorry, that got cut off. The hepatitis C is among those that are especially at high risk, including IV drug users. If they have multiple or anonymous partners, they should be screened more frequently for STDs, and you might want to evaluate them or refer them for evaluation for a pre-exposure prophylaxis regimen. And then vaccination for hepatitis A and B is recommended for all non-immune MSMs. So all patients who are MSM should be either offered to be vaccinated for hepatitis A and B, or at the very least should have antibody titers to confirm immunity. So smoking and tobacco use, we discussed this a little bit previously, but LGBT people smoke at much higher rates than non-LGBT individuals. And if you look at the data, it's about 10% more of LGBT adults smoke as opposed to 20% of the heterosexual counterparts there. The 30% of transgender people smoke. Now, again, that's based on limited data, as we've been saying all along. The true numbers may be a little bit less, or more than likely are actually higher. So as a clinician, we want to understand the motivation for smoking. This is true of all patients, but especially within the LGBT patient, stress may be related to marginalization, societal or family marginalization, LGBT social issues, as we discussed earlier, especially from a generational perspective. More LGBT individuals were likely to be at bars and clubs, and so smoking was more likely, and then targeted marketing as well. Nowadays, what we're seeing among LGBT patients is not so much the bar and club scene, now it's the phone scene. And so everyone knows about Tinder and Bumble. What you may not have heard of is something called Grindr. It's an application where you can actually see how far away someone is from you who wants to have anonymous sex in most typical scenarios. That obviously increases the amount of STDs that can be spread if protection is not used. And so that partly was to describe our previous HIV rates increasing. The hypothesis at the time was that it was due to increased technology and the ability to access someone who wanted to have unprotected sex at any time, 2 a.m. in the morning, et cetera. The encouraging news is that the health department and the public health initiatives that have gotten out there in terms of addressing those HIV increases have seemed to, at least based on current data, be working, and more people are either using protection, having less risky sex, or are on some sort of pre-exposure prophylaxis. As it relates to smoking, I want to make sure that you go back to that motivational interviewing, and the 5 A's has been used in validated studies to look at how you can actually assess someone's ability to quit smoking and support them throughout it. So you want to ask about tobacco use, advise to quit, assess willingness to attempt to quit, and assist in their quit attempts. We're going to talk about a controversial topic, and I don't mean controversial like my preceding slides have all been, but actually controversial in the medical literature, and that's looking at HPV and anal cancer, especially in the MSMs. As we're all aware, and it's been strongly documented, HPV is strongly linked to the risk for anal cancer, as well as oropharyngeal cancer, cervical cancer. 95% of anal cancers are caused by HPV. HPV-16 is the most common subtype associated with anal cancer. Sexually active HIV negative, this is important for me, HIV negative MSMs in all age groups have a high prevalence of anal cancer as compared to non-MSM patients. In fact, if you had a male who had receptive anal intercourse and more than 5 sex partners, you were at an extremely elevated risk for HPV-associated anal cancer. The incidence in the general population is about 1 to 2 per 100,000 per year. In HIV-negative MSM populations, that jumps 40 times, so 40 out of 100. And in HIV-positive MSM populations, 144 at the uppermost limit there out of 100,000. So it's a huge number as compared to the general population. Anal cancer has become one of the most common non-AIDS defined tumors among HIV positive individuals, 86% prevalence of HPV infections among HIV MSMs, with more than a fourth of them being positive for the subtype 16. Among HIV positive MSMs, the incidence of anal cancer is roughly 10 times greater than the current rates of cervical cancer in the general population for women. So how do we prevent it? For me as a primary care doctor, that's what I like to focus on, is preventing ailments. So the CDC recommends that all women can get HPV vaccinations through age 26. Young men can get vaccinated through age 21. However, if you are a male who has sex with men, that age is bumped up to 26. Or if you're a male who has some sort of compromised immune system, including HIV, it's increased to age 26 as well. I will tell you that I've had a lot of conversations with our colorectal surgeon at our institution, who sees a lot of MSM patients who have had anal cancer. And what he does in his practice, based on the colorectal literature, is if there's ever been a history of squamous cell carcinoma, anal squamous cell carcinoma, he actually vaccinates them at that time with Gardasil. And the reason for that, regardless of their age, and the reason for that is because it's actually been shown to increase clearing of the HPV virus and decrease incidence in terms of recurrent anal squamous cell carcinoma. So what about anal cancer screening? This is where the controversy comes in. So a DRE, obviously we've gotten away from that in terms of screening for prostate cancer. There is some evidence recommending it in terms of all of your MSM patients, especially your HIV positive MSM patients, or any MSM patient who has had anal warts before, but there is no consensus among that right now. MSM and women with a history of receptive anal intercourse or abnormal cervical pap test, there is some evidence of doing anal pap tests. However, that is a weak recommendation, and there's not really good quality evidence on that. How would you perform it if you were going to? Just like your typical pap smear, it's used using a standard pap kit, and you use a swab or cytobrush into the anal canal and rotating against the anal walls and sent off to the pathologist. The sample is then graded based on the Bethesda 2001 grading system, so you'll get a report from the pathologist that is very similar to all of your other pap smear results. The biggest issue with this, if you're going to perform it, is insurance coverage. So conversation with the patient about that ahead of time may be necessary, or in some cases, my least favorite word in medical, my day-to-day of medicine is prior authorization may be required. If you do have an abnormal cytology, ASCIS or higher, they should be referred to your friendly colorectal surgeon for a high-resolution anoscope with biopsy to grade the lesion. If you look at the national data, the CDC, the USPSTF, American Cancer Society, and the IDSA do not support routine screening, but that's because they say there's not, the evidence right now is so mixed on it. I will tell you the New York Department of Health, their guidelines actually do recommend for all MSM patients to have it at least every 3 years. For any MSM patients who's HIV positive, they recommend it every year. But national guidelines do not support that currently. Switch over to another HPV causing cancer, cervical cancer. Rates of cervical cancer are as high for lesbian and bisexual women as they are for heterosexual women, and that they have statistically significant lower screening rates compared to their heterosexual counterparts. The other scary part to me is that if you're a lesbian or bisexual woman, you're much less likely to have a mammogram. And that is 100% on the fault of the primary care doctor, especially if these patients are being seen for all other reasons, but they're not being offered mammograms. That is a major issue for many reasons, but the biggest one is that lesbians are less likely to have parity in the past, and so they are less likely to have given birth, and therefore their rate of breast cancer is actually higher compared to their heterosexual counterparts who have given birth. Transgender male, so that would be female to male patient. The majority of them do not undergo a complete, what they refer to as gender-affirming surgery, so they've not had a complete hysterectomy, although some have. If they still have a retained cervix, they should still have cervical cancer screening. The same is true for a transgender female, transgender woman who has a retained prostate. They should still undergo prostate cancer screening, although obviously right now the literature is all over the place on what we do with prostate cancer screening. Finally, youth issues. There's developmental challenges. Part of growing up and being an adolescent is just discovering your own identity, and that includes your sexual and gender identity. And there may be ethnic challenges that they need to negotiate. They also may need to decide when and whom to come out to. And some youth have a strong relationship with their family and they feel comfortable coming out to their family. Other youth may come out to friends or teachers or physicians prior to coming out to other family members. As a result of that coming out process, they deal with internal and external homophobia and transphobia, bullying, and societal marginalization. They may feel isolation, and that can lead to increased suicide risk. So discussing identity, whether that's sexual identity or gender identity with youth, the youth may decide to disclose or not disclose their identity to you, and that's okay. I try not to get pushy with any of my adolescents that I'm seeing in clinic. Youth are actually more likely to reject labels of any kind, getting back to that binary system that we discussed earlier. Today, anyway, our youth are more likely to reject all sorts of labels, and that includes in terms of their sexual and gender identity. And they are more likely to use the terminology as queer compared to gay, bisexual, or lesbian. So concluding thoughts, one is avoiding assumption. Don't assume you know the person's gender identity or sexual orientation based on how they look or sound. Don't assume you know how a person wants to describe themselves or their partners. And don't assume all of your patients are heterosexual and cisgender. So addressing health disparities leads to health equity. If you're not comfortable dealing with patients who identify as LGBT, or if you want more information and help, make sure you identify local resources that can help you, and help to educate colleagues and staff. That's a really important part. So that's it. Thank you very much.
Questions? Oh, there you go. Here you go. Okay. So,
Exercise.
This is a 6-part question.
Oh, yeah.
Well, maybe just 3. Do you know anything about the statistics of laryngeal cancer in MSMs?
That's a great question, and actually I thought of it this morning and then promptly forgot to look up.
Well, I can look it up then. All right, that's homework.
I will look that up, and hopefully I'll get back to you.
Oh,
here
it's
shortly.
okay. I was just
No,
curious.
but it stands to reason it would be increased.
I would assume that to be true. Yep.
Do you have any screening that's recommended or
No,
even available?
currently
You
there
take
is
a
no available.
Cashmere brush and do the throat?
Well, there are some dentists actually that perform some high-resolution screening for HPV-induced cancers, regardless of sexual identity or behavior. But I personally have not instituted that from a HPV standpoint. However, for a gonorrhea and chlamydia standpoint, I do routinely actually perform oral pharyngeal screening as well as rectal screening, because in many cases, and I've had this too many times to count, they're asymptomatic and they are carriers for gonorrhea and chlamydia, and they actually require treatment as well.
So oral and rectal
Yeah, so if
swabs
they've
are
had
done?
any, especially unprotected sexual intercourse, whether it's been rectal or pharyngeal in the last 6 months, I routinely screen them for that.
Well, thanks.
Other questions?
And that's not one, by the way, you want to send to the lab to do, because then they'll call you and get very angry. What are you asking me to do here? So you want to do that in your office.
Anybody else?
If I may make one quick thing, I love Shark Tank, and this product was on Shark Tank. I don't know if anyone else has seen Shark Tank, so I'm so happy that you guys have these things, because they're really nice. Yeah.
Yes.
Victor Campbell has a question.
Okay. Pediatric endocrine, again, we're dealing with the newborns with these genital ambiguities and trying to explain it to the parents. Most often congenital adrenal hyperplasia virilizing. Usually quite satisfied to go with the female gender of rearing with the appropriate surgical procedures. I've come upon one Guatemalan immigrant mother who has a son who's now 2.5 years old and a daughter who's 6, and wants her son to be a boy, And the 2.5-year-old says, I'm a boy. And we're addressing it from the point of view of knowing genetic as well as clinical total androgen insensitivity syndrome. I've given her the Spanish translation of the organization. The boy is actually talking very good English at the moment. He seems to be coming along. But as you can see, we're projecting problems of socializing with this chosen boy gender. Basically looks certainly very pre-pubertal female and can fit in all there. I just wonder when he goes off to school, fitting in with the other boys in the restroom, as we say, and trying to get psychology perhaps to evaluate the situation as he's entering kindergarten to see what the total agreement is.
Absolutely, and just more globally with transgender youth in particular who there's this organization called WPATH, which don't ask me to, again, more acronyms, but they are really the world's authority in terms of transgender hormonal replacement therapy. And what they recommend for adolescents, anyone less than age 14 or lower, outside of any true medical condition in terms of adrenal hyperplasia, et cetera, that they have appropriate psychosocial support from a psychiatric standpoint, counseling standpoint, but it gets very controversial in terms of using any pubertal blockers, so your GnRH antagonists, et cetera. However, and the reason for that is because there's been some decent studies that have been done that have shown that about 30% of those patients where medication was started later on in life actually no longer have that gender identity, that they actually have gone back to whatever their sexual, anotypical, phenotypical sex was at birth. However, once you get to 14 and above, it's less than 5%. So I know I took a more global approach on that, but it was an excellent point.
We do like to try to be sure that the caregivers are pretty much in agreement as to the gender of the child before they go home, and that's the best we can do to get started.
Yeah, that can be difficult, the conversation.
It can. Thank you.
It's complex enough.
It is.
Then you put culture, global differences in culture.
Absolutely. And so for part of that is understanding the cultural differences. That is the first step, and that is huge, and it's very difficult, complex. And quite honestly, a lot of times you're never going to get there. But making sure that you have that appropriate support in place, you should ask the questions, and you should make sure that if you're not comfortable, that you refer to someone who is, especially, well, who is. But there's a lot of psychiatrists and counselors that can help.
Increasing in their
Absolutely.
That's actually really positive.
Yep.
Any other questions?
Thank you so much.
Thank you.
Thank you very much.